Yuka Manabe is a professor of medicine with adjunct appointments in international health and in molecular microbiology and immunology. But more importantly, from my perspective, she's the Associate Director of Global Health Research and Innovation at Johns Hopkins University. She's also at the forefront at Hopkins on coordinating a lot of the diagnostic response. And as such, we're very fortunate to have her spend some time with us. It's pertinent to know that Yuka lived 5 years in Uganda, heading up a laboratory at the Infectious Diseases Institute. And so really does have a firsthand knowledge of the restraints and availability of diagnostics in the developing world. So Yuka, without any further ado, I'll turn it over to you.
Thanks, Tom. It's really a pleasure to be here, and thanks for joining the Center for Global Health's Zoom conference series. So I have had the pleasure of working with CJ Royland, who's a second-year medical student here at Johns Hopkins, on this presentation, and she's going to kick off our presentation to talk a little bit about the state of diagnostic testing both in the US and worldwide, and then I will join the second half to talk a little bit about the current diagnostics. CJ?
Thank you. So if you could just advance the slide to the next one. So just to introduce a little bit of the history, I think most of this is information that we're already familiar with, but it was only in December. This may feel like the longest few months that we've ever had, but it was actually only December 31st that the WHO announced this cluster of cases of pneumonia. A month later, it was declared a public health emergency of international concern, and the next day, a public health emergency here in the United States. It wasn't until February 11th that the disease was actually named COVID-19. On the following slide, you'll be able to see a timeline of some things that have happened here in the US, just to look inwardly a little bit on the evolution of testing and diagnostics here. So like I said, December 31st was the first identification of these clusters of pneumonia cases in Wuhan. On the 17th of January, the WHO released a protocol for an RT-PCR test. About a week later, the CDC announces its own protocol that was distinct from the WHO's protocol that will be distributed to public health labs with the permission of the FDA. And it was a few days later that other labs and clinical microbiology labs like Stanford started to develop their own testing protocols, but were unable to utilize them due to FDA regulations. So it was February 4th when we finally approved the CDC's testing, but a number of issues started to arise with the labs that were receiving these tests. And on February 12th, the CDC publicly disclosed that there were issues with this test. And so there started to become this huge backlog of testing because clinical microbiologists that had developed their own assays were unable to test samples because of the major process of acquiring emergency use authorization status from the FDA. So a letter was written by a group of these microbiologists to Congress complaining about the process restricting them from being able to do adequate testing. And it was the next day that the FDA eased the regulations and made it easier for these labs to obtain emergency use authorization to start performing PCR testing. And so a couple of the major companies in the private sector began testing in the following days, LabCorp and Quest. And then as we started to see this emergence of serological assays and antibody testing, the FDA sort of quickly announced that these tests could be distributed as long as they were distributed with a disclaimer that they had not been reviewed. Some have suggested that they've swung in the opposite direction of the rigidity that they demonstrated early on in the pandemic with all of the restrictions that led to the delay of the PCR testing becoming widely available. And so as an example, on April 16th, 91.6% of testing is done by the private sector, whereas the remaining small portion is done by the CDC and public health labs. So you can see here on this graph that the CDC did scale up public health laboratory testing beginning sort of in early March, mid-February. But if we take a look at comparing this level of testing to the greater total level of daily COVID tests, you can see this light purple line on the bottom here is the public health testing, and this gray top line is the total. So you can see that this huge number of tests is being done by the private sector, and that this plan of the United States to have its public health laboratories be the only ones to test has proved to be completely inefficient. So if we then look more globally and we take a look at the levels of testing per 1,000 people in different continents. The top left here, we have North America. Below that is Europe. Top right is Africa, and below that is South America. You can see generally these trends of lower levels of testing per 1,000 in countries and regions with lower income. You can see that the US is steadily rising and reaching a plateau, not reaching some of the levels of European countries, but that there is some association you can see with income level and daily tests per 1,000 people. And looking at this another way, this is tests per 100,000 people. You can see sort of a familiar looking distribution of these lighter colors correlating with fewer tests per capita in areas of lower income compared to areas of higher income. So on the next page, it makes it difficult for us to interpret graphs like these that tell us that we have lower numbers of cases in lower middle income countries and upper middle income countries. It's hard to know whether or not a graph like this is good news. It's hard to know whether or not there are actually this many fewer cases in these countries when we see a graph like the slide previously that discusses how little testing there is in these areas. So it makes it you have to look at both sides of the coin, whether or not there's actually fewer cases or whether or not the paucity of testing is making it appear that way. And so now I will let Yuka take over to talk about some of the testing specifically.
So thanks so much, CJ. I've relied on this graph, though I will say that it is a diagram made for illustrative purposes. But it's important to think we've been talking largely in this country about RT-PCR testing, which is this red line, where you would start to get RT-PCR tests that are positive even during the asymptomatic phase. Once the person develops symptoms, we again might see RT-PCR positivity with a median time of being positive out to about 15 days, so that this curve starts to decline. The total antibody, though, starts to increase sometime around day 5, such that you have IgM first, IgA next, and then IgG. But you can see that if you decided to test somebody serologically, say at day 3 after the onset of symptoms, you may be very unlikely to find a serological response. It's important to also show that you have a viral response phase in the beginning and then a host inflammatory phase. And during this host inflammatory phase, they may or may not have RT-PCR positivity, but often we've found that total antibody can correlate with severity. So using this maybe as a guide for the future discussion, I wanted to talk a little bit about molecular testing. So here in the United States, between March 12th and April 28th, 13 automated integrated diagnostic tests for SARS-CoV-2 testing received emergency use authorization from the FDA. Of those, the majority of them are large machines that can do high throughput testing. And that's been really important for many of the central laboratories. I thought it was important, though, to highlight the 5 platforms that are modular and also integrated. And when I say integrated here, I mean that the extraction of the RNA and then the reverse transcription leading to cDNA, and then the subsequent amplification by polymerase chain reaction, or PCR, occurs all in one module. It occurs in an integrated way. When I say modular, it means that each test is separate. So you can see here, for example, the Cepheid machine. This is the BioFire film array, the Abbott ID Now, and the Misa Biotech Acula. There's one other modular machine, that's the GenMark ePlex. That is a large machine and a relatively small company and is unlikely to play a role in the developing world. So I think the interesting thing about these 4 is that you could imagine that these could be placed maybe in peripheral places, you would obviously need electricity, but potentially these could play a role in places where large machines or problems with centralized hubbing could occur. The one I'd really like to highlight, though, is the expert gene expert, the Cepheid machine. And the reason I'd like to highlight that is, first of all, this company has decided to have cartridges that are going to go to low and middle income countries compared to just high income countries. And in addition, Expert already has a very large footprint worldwide. And the reason for that, of course, is because Expert is the workhorse for near point of care delivery of tuberculosis testing. And so this machine is sort of all over the place. And if we had to think of a rapid scale up, this would be a possibility for getting molecular testing to outside places. BioFire film array has been used a lot for acute febrile illness testing and for respiratory testing. So this machine does have somewhat of a footprint worldwide. And we know here in the US, where you are will often determine how much of an impact you can have on COVID testing. The Abbott ID now is primarily here in the US, but it's nice because you can take a swab and directly put it into the machine and get a result in 13 minutes. It's probably one of the fastest. Cepheid 45 minutes, BioFire an hour. And then the Misa Biotech Acula, which is a relatively new machine that has pretty good sensitivity, takes about 30 minutes. So here we also have some triage ability and some interesting platforms that could be amenable to places where there is less technical expertise. Here is a page that I took off of the FIND website, the Foundation for Innovative New Diagnostics, and you can see the website up here. This is just one page of several where they show the different companies, the gene targets, and so forth across, letting you know what the capabilities of each of the platforms are that have received or have been used in different countries. The thing that I wanted to bring up here in the middle is the SARS-CoV-2 complete genome of 29,000, almost 30,000 nucleotides. It's really important to see that there are different genes that are contained within the SARS-CoV-2 genome, and almost all of them have been targeted by these various tests. So for example, if you look along the gene target column here, you can see the S gene, which is the spike gene. You have the RNA polymerase gene, the E gene. This is the ORF1, which you can also see here. Most of the tests that have been used have more than one target. And this is, of course, useful in case the SARS-CoV-2 starts to mutate over time. You might still be able to detect SARS-CoV-2 efficiently, even if it changes, if you have two gene targets. So in general, these tests have 2 targets each. So what are the global issues with COVID-19 molecular testing? Well, first of all, it's expensive, and you know that that's because the polymerases in general are not, they are the sort of cost limiting part of the test. Also, many of these countries have limited lab capacity. Countries that have dealt with pandemics before often have centralized lab capacity where they have already been able to offer testing. And you'll see that if you look at the countries that are doing testing, it tends to be ones that have already decided to have pandemic preparedness. And they have a reference lab that's currently doing the molecular testing. This is a hub and spoke specimen transport system, and it has been activated for COVID-19. Nasopharyngeal swabs are difficult to come by and difficult to perform, transmission problems. And I think there's a need to validate different sample types, including self-collected oropharyngeal and nasal swabs. And I think this is going to become a problem internationally, and we need to think about how to validate those different swab types. Globally, there are swab shortages, but interestingly, sometime in resource limited settings or in middle income countries, they're producing their own and they do it efficiently. I would say that because we rely on companies in this country, the swab shortages have been felt perhaps more acutely than you might see in other countries. I think there are biosafety concerns, as I mentioned, with getting samples that we really need to think through. And we might have to come up with UV solutions, like having places outdoors where you would be collecting samples. And then finally, what are you going to do with patients who you diagnose with COVID-19? in many of these places, people live in congregate settings just in their own family, and trying to achieve isolation will be very difficult in crowded households. So will there need to be central places where COVID-19 people go so they can be isolated from other household members who are at greatest risk for getting the disease subsequently? So I just wanted to talk a little bit about molecular testing and to talk about the correlation between viral load and illness severity. There's a nice paper that came out from China looking at showing that 90% of patients with mild disease tested RT-PCR negative by 10 days after onset of illness, whereas those with more severe illness, here in red, tended to have a longer duration of RT-PCR shedding. All patients with severe disease tested positive on or after day 10 in this study. Here's a nice paper from the German group. This was 9 relatively mildly sick patients whom they did not only RT-PCR testing, but also did culture. And that culture was in a virocell model and obviously had to be done at biosafety level 3, but was one of our first glimpses of being able to look at, first of all, the duration of RT-PCR positivity and how it then correlated with positive cultures. And what you can see is that as the RT-PCR levels went down over time, the likelihood of being culture positive also decreased here in nasal swab specimens. So this was reassuring that as people got on and their RT-PCR results became higher cycle thresholds and then went negative, that likely these people didn't have culturable virus. Interestingly, about 5 days ago in the New England Journal, this paper came out from Melissa Ahrens and the University of Washington group. And I thought this was really interesting. This was from a skilled nursing facility. This had 16 people that had typical symptoms, 4 people that had atypical symptoms, and 24 that were in a pre-symptomatic phase. They had yet to develop symptoms. If you look at these circles, they show the cycle threshold for, in this case, the nucleocapsid target gene. And as you know, as the cycle threshold increases, it shows that there is less and less viral RNA that can be detected. So it takes longer to amplify that viral cDNA or viral RNA. And then what you can see here is the red circles compared to the black circles are when you can see culture positivity. And so this now was not reassuring in my mind to show that even people who had high cycle thresholds here were growing out virus. And so as opposed to what we had found here in the German article, maybe people with higher cycle thresholds still have culturable virus. One thing to me, though, that was reassuring is that most of these were found in the pre-symptomatic group. So questions arise. How does RT-PCR positivity link with culture positivity? Is there a difference in pre-symptomatic versus symptomatic disease? And in turn, how does RT-PCR positivity then link with transmissibility within a household? And I think these are key questions that still need to be answered. So I've written stay tuned here. So next I wanted to turn to serologic tests. I think there are different types of serologic tests. This is well laid out actually in a Center for Preparedness here at Hopkins. They have a very nice monograph white paper that they've put out. But here you have the type of test and then the readout, how it's done, what they're actually looking for, and the time it takes. So if we look at this first column of rapid diagnostic tests, many of us are very used to seeing this for particularly things like HIV, syphilis, we have for viral hepatitis. These are in general qualitative assays. Yes, no, a binomial outcome. They can be point of care if they are in a lateral flow test like a pregnancy test would be. They are generally performed on whole blood, but many of these are also able to be performed on plasma and serum. They look for IgM and IgG in general, and they take 10 to 30 minutes. It's important to notice, though, that almost none of the RDT tests that have been FDA emergency use authorized can use finger prick blood because they have not been validated with that sample type, believe it or not. The next would be the ELISA assay. Many of you are familiar with this. This can be both qualitative and quantitative. It is a lab-based test, usually done in a 96-well plate. It looks for binding of the patient antibodies to a fixed viral protein that's usually stuck to the bottom of the well. You can use both plasma and serum, and there are tests now that detect IgM, IgA, and IgG. For a skilled technologist, this can take anywhere from 2 to 5 hours, depending on the number of samples that are being processed. And finally, importantly, these neutralization assays. This is to see how the patient's serum or plasma can then inhibit the replication of the actual virus in question, in this case, SARS-CoV-2. These are quantitative. It's a lab-based test. Because we're actually growing SARS-CoV-2, it requires a biosafety level 3 lab, which are generally very much less available than other types of lab space. And it's a live virus assay that tests, as I said, the ability of the patient antibodies to confer what we would call protective immunity. This would be a neutralizing titer, and this takes up to 5 days. So this is not an efficient test in terms of time. So what are the serologic tests actually looking for? Well, here's a cartoon of the SARS-CoV-2 virus. Some of them look for nucleocapsid, others look for spike protein, which are these things that are sticking out from the outside of the coronavirus that leads to its name, so it looks kind of like a crown. Interestingly, some of these parts seem to be more specific than others, and others can be more sensitive. So if we look at the spike protein, the full-length spike seems to be less specific, but it's more sensitive, whereas the receptor binding domain, also known as the RBD, tends to be more specific, but perhaps less sensitive. Similarly to full-length protein nucleocapsid, again, is sensitive and perhaps less specific, though it will depend on the type of serologic test or the actual company that you use. So how should serologic tests be used? I think this is a source of great debate. One would be surveillance to estimate population proportion that's been exposed or previously infected. This has, of course, been done famously in Germany. They are now even issuing immunization certificates to individuals based on their test results. And many other countries are looking into whether or not that's feasible for them. I think, though, this is a little bit of a buyer beware. I think most of you know about the story of the UK, where their new tests that they bought very many of turned out to not have good performance and were not maybe properly validated before they were purchased. So it's important for you to realize that not all tests, serological tests, are created equal. And I think it's really important to think about vigorous validation before adopting any test in any particular hospital or healthcare setting. So the one that many people are interested in, and I personally have received many phone calls from friends, from family, from colleagues, and other people about how a serological test could be used in an individual case. So remember, if you're going to use it in an individual, I'm going to remind you about this cartoon that I showed earlier. If you do it very early in disease, it may not be so useful, but one use case that we're using here within the Hopkins health system are to diagnose infection in patients who are nasopharyngeal swab, RT-PCR negative, who have symptoms very consistent with COVID-19 and who've been sick for more than 10 to 14 days. We might use a serologic test in this case to try to make the diagnosis when the RT-PCR was negative. And we know that false negative RT-PCR occurs, perhaps because you didn't test at the right time, the test itself was inadequate, the NP swab was not a good swab, or because the test itself wasn't sensitive enough, or you didn't go to the site of disease, say deep in the lung. So we can also show COVID-19 exposure in a person who had a plausible suspected infection in the recent past. So for example, if you're a health worker and you got a febrile illness with respiratory symptoms, you might, that you got over, you stayed home, you were furloughed, and then you came back, maybe you would like to know whether or not you had really been exposed to COVID-19 and you want to see if you had an IgG response. This is okay now during this time of the epidemic, but fast forward maybe a year and a half from now, and maybe COVID-19 is still around. Then how useful is a serological test in that patient? Well, maybe acutely could be useful, especially if you combine it with an antigen test, but maybe the IgG itself is no longer particularly useful. We also have to remember that serological tests in individuals don't tell you anything currently about protective immunity, as I alluded to earlier when I talked about neutralizing titers. So I also wanted to bring up something that came on early on in our serological working group. I think, in fact, Tom was the one that first brought this up. You know, when we talk about HIV, we often say, do a sensitive test that maybe is not so specific first. If that one is positive, do another test to confirm. And whether that's another serological test or a test like a Western blot, or maybe an antigen or an RT-PCR test, you might do sort of combinations of tests in order to have more diagnostic certainty for an individual. And I think this is probably where testing is going to evolve over the coming months. So I wanted to leave you with some of the issues, though, with serological testing that I think are worth pointing out. The different antigens that I showed you a couple of slides ago, whether it's nucleocapsid, full-length spike protein, the receptor binding domain, all of these antigens probably have different sensitivity and specificity, which may also be dependent on the timing after infection and the isotype. So is it IgM, IgA, IgG1, 2, or 3? There are quite many isotypes of antibodies. And so here in the graph, this is a very nice paper from Zhao and colleagues, where they showed that if you look over time in the number of days that a person has been infected, and you looked at the cumulative seroconversion rate, you can see that when you look at IgG, that not everybody actually seroconverts. And in fact, if you look at these, it's maybe kind of small on your screen, but if you look over here, not everybody necessarily, even after 21 days, will completely seroconvert. And this has been shown, in fact, in another paper by Wu and colleagues, where they showed that 5% of the patients in their serosurvey of 175 patients never made an IgG response. This has also been shown in the convalescent sera studies, where they're trying to collect convalescent sera from patients who have had COVID-19 RT-PCR proven disease. And they're finding about 1% of people don't make an antibody response at all, and about 30% make a very weak antibody response, such that their convalescent sera would not be useful for those clinical studies. So lest you think I'm just going to be depressing the entire time saying how many things we don't know, I think in general that RT-PCR and serological tests will, as was said in the Diagnostics Summit by Galit Alter yesterday, be the meat and potatoes of what we do for diagnosing COVID-19. The World Health Organization had a virtual meeting on the 24th, and I wanted to read what the WHO Director General said. Our shared commitment is to ensure all people have access to all the tools to prevent, detect, treat, and defeat COVID-19. No country and no organization can do this alone. The Access to COVID-19 Tools Accelerator brings together the combined power of several organizations to work with speed and scale. And I think that the WHO is going to bring us together around how we can fight this truly global pandemic. And so I leave you with the words of a friend in the Ministry of Health from Uganda, who said this to me: life is not about waiting for the storm to pass, but learning to dance in the rain. And so with that, I would be happy to take any questions. I think this double rainbow was the one that I saw the day that I arrived at the Infectious Disease Institute in Uganda, and has become the symbol of our combined fight against COVID-19. So back to you, Tom.
Great, that was fantastic, Yuka and CJ. Both of you did an outstanding job, really giving a great overview and going into detail on a number of the issues. I gotta tell you, as it always evolves, as you're giving your talk, questions upon questions were rolling in. So I'm gonna try and go through some of these questions. We're at the half-hour mark, and so for those who need to leave, we understand. for those who want to stay on, we'll go through some of the questions. And I'll go through some of these as best as possible. Let me start out with one of the questions, which is really when a patient presents with symptoms, what's the exact protocol for testing step by step? What should I do first? And they put questions: chest x-ray, serology, RT-PCR, and if the person is testing negative yet has symptoms, should that person be tested again? Should it be within a few days, few weeks, or what do we do? So let me stop there. They then get into cost, that these tests are not free for US residents, but other countries are not charging for them. You go.
So I think it's a great question. I think the current standard would be if you have a person who's having symptoms, that you would do a nasopharyngeal swab. There's emerging evidence that an oropharyngeal swab may be just as good. And in some cases, there have been some early reports that maybe even salivary testing could work. And that may really change our ability to test more people as long as we have a good enough swab supply. Now, let's just say that you fall in the 15 to 30% of people who might be RT-PCR negative, but you think the person has a credible story. So there's a couple of things that you could do. If they are, say, more than 10 days out, you could do a serological test. Which serological test you would use would be dependent on what your hospital system has validated, at least in the US. I think that there are increasing data coming out for international settings where the Foundation for Innovative New Diagnostics is trying to collate data from very many different places to do independent evaluations of the various tests that are available on the market. They have a line listing of all the tests that are currently available, and they're soon going to have performance characteristics of those tests and how rigorously they were evaluated. For example, did they check specificity, say, with people who were infected with other coronaviruses, but not SARS-CoV-2 and COVID-19. Another possibility is to do chest CT. It is true that patients who have COVID-19 have a particular kind of ground glass infiltrates, as we say, a particular look on CT scan that may be very characteristic of people with COVID-19. There are papers coming out in China where they were using a lot of CT scans to diagnose people. And it's there where we get some inkling of the false negative rate, where they had someone who had a very suggestive CT scan, but actually had RT-PCR negative. So I think that there are several ways that you could go about testing different sample types. Also, we have found here at Hopkins, for some of the people that were false negative, later on in disease, as the SARS-CoV-2 binds to the ACE2 receptors deeper in the respiratory tree, that actually bronchoalveolar lavage or sputum may be better sample types to make the diagnosis. So in terms of cost, that wouldn't necessarily be my area of expertise. Clearly, a CT scan is more expensive. I would say that just the kit costs for most of the PCR tests here in the US range from about $25 to $50. That's just for the kit. That's not tech time. That's not including any of the other things with resulting and all the things that you have to do to have a high quality lab result. So these are expensive tests. And once again, I think that the rate limiting thing is the polymerase. So maybe there will be concessional pricing. I think, you know, if the government buys in bulk, sometimes they can get better prices. So I often tend to, at least for low and middle income countries, not pay attention to the price and hope that the global market adjusts itself in order to do what's right rather than what might be profitable. So I don't know if that's helpful.
Well, I think you did it as best as can be. Each country is going to take this on in a different format, different situation, depending on the resources, capacity, and so forth. But here's a more difficult question than that one, and that is how, since none of these tests are really FDA approved, they do get an approval for what's called EUA, but it's not the same rigorous approval system that the FDA often gives to diagnostic tests. how do you know which test is better? How do you find out about their performance characteristics? Is there a cheat sheet, in other words? Yuka, are you there?
Yeah, I got it. Sorry. So for the RT-PCR tests, we have found that most of the commercial tests have a relatively similar level of sensitivity. Those are data from Heba Mustafa in our molecular microbiology lab, who's done a fantastic job offering tests. She told me yesterday that she has crossed the 20,000 test mark here in the Johns Hopkins medical system, which I think is fantastic and a tribute to her resourcefulness. But there is only one test that has suffered maybe a little bit from sensitivity, and that's the Abbott ID Now. I think the reason is because people are putting the swab into viral transport media, which they're then loading into the machine. The way the machine was intended to be used was to take the swab and directly swish it around in the machine. So if you use it that way, I think even that sensitivity is okay. So for RT-PCR, the relative sensitivities have also been posted on the FIND website, and you can look and see. Their targets are all different. They both use 2 targets. All of them use 2 targets, and I think you can get a relative sense. For molecular testing, so I would say largely they're okay. The ones that use extraction and then PCR, those kits that are sort of separated, that if you use automated extraction, I would again say you probably are going to get consistent results. If you're doing individual extractions, all of you know who've ever used a QIAGEN column, I mean, things can go wrong. So there you might lose sensitivity if you're doing these non-integrated systems. The serological test, though, is the place where basically the FDA sort of disavowed all, they just said, if you make one and you want to put it out there, and then we'll look at your data afterwards, but you can put it out there. You might want to wait for the ones that have had an emergency use authorization, because at least the FDA has looked at that data. They have to pursue that after they start distributing it. They have to pursue it or they won't be able to continue to distribute it. Those that are being distributed without an FDA EUA probably are not as high quality, but the number of specimens that they have to test in order to get an EUA is the lowest bar in the history of the Food and Drug Administration. So I think you might want to wait for some of these independent evaluations. In fact, Tom Quinn and Oliver Leindecker here at Hopkins are doing a large comparison of many of the commercially available ELISAs and lateral flow devices. The point-of-care lateral flow devices are being tested by Bill Clark. So within our health system, we're trying to do our level best to do an independent evaluation. Stanford is doing it. I think the Reagan Institute is also doing it. Down in Atlanta, I know that group at Emory and at Georgia State are also doing independent evaluations. So I think you might want to look for these independent evaluations in addition to decide which test to use.
Oh, that's great. And Charlotte Gatos weighed in saying there's 2 recent publications of the comparison of the test in JClin Micro, comparing many of the available tests. So take a look at those publications. Also, the Center for Global Health Security at Johns Hopkins has this white paper that Yuka referred to that also does go into detail. And finally, I'll just add in that if you go to the FDA EUA site and you can pull up what the manufacturer submitted to the FDA, those submissions are available and you can see what kind of validation they did do. Some are satisfactory and some are not, but at least it gives you an idea of why the FDA gave them an EUA. I want to bring CJ in next. There's a question about what, in your review on testing by country and so forth, is there a recommended number of tests per 1,000 population that should be carried out to know the country's conducting a sufficient number of tests? Is CJ muted or?
I am muted, sorry. I saw that question and I think it's a really good and important question. And I don't know of any guidance out there right now. I don't know if you know the answer to this question on.
No, I was just going to say, I mean, I think a lot of it has to do with your contact tracing. So for example, like Singapore or South Korea, where they quickly were able to isolate and put people, probably have a lower number per 1,000 per 1,000 people, but that doesn't necessarily mean that they're not doing a good job. So I think it's important to think about where you are in the epidemic and how many you should do. If you have a generalized community spread like we do here in the US, you probably have to have more tests per 1,000 in order to keep things under control. I think the real question for us as a country here in the US will be, after we've flattened and people see a downturn in the number of cases, how are we going to react as a country when we're trying to keep things under control? And that's when we're going to really have to do a lot of tests to keep things under control. And the question that I have now is, do we have the supply chain and the capacity to do that? And I'm not sure. We may be one of the richest countries in the world, but we still are struggling, I think, in terms of what we do.
Well, speaking of one of the richest countries in the world, here we are in New York City. We've been getting strong warnings in the city health department about the very poor specificity of serologic tests, namely a lot of cross-reactivity with other coronaviruses. Can you speak to that? You sort of just did, but for the New York folks online, this is an issue.
Yeah, so I think what people have realized is it has a lot to do with the homology or the sort of similarity between the alpha and other beta coronaviruses compared to SARS-CoV, MERS-CoV, and SARS-CoV-2. And so the place where there is the most sort of distinctive is the spike protein. And it's probably the S1 part of the spike, and in particular the receptor binding domain, that is the most specific. So when you look at tests that are looking for nucleocapsid or for full-length spike, they tend to be sensitive but not as specific. So I think we're going to get more information with that as time passes. That's been the impression so far. And that's why you'll see that every single FDA emergency use authorization has a disclaimer that says that you can't know if it's specific to SARS-CoV-2. And that's important. I think it's important because if you think about coronaviruses in any given season, the Center for Excellence in Influenza Research here at Johns Hopkins, of which I'm a part, does a surveillance every year. And about 35% of people who have upper respiratory tract infections have it due to coronavirus. And so regular coronavirus, upper respiratory coronavirus. So this is a really key question, and I think we have to get that specificity that we need based on the target and the isotype. And so I think I alluded earlier, maybe you want a really sensitive first pass, like maybe a nucleocapsid or a full-length spike first, and then maybe do a more specific one second that might not be as sensitive, but definitely will give you the specificity. So that's something I think Tom and I have talked about and others have talked about, but I think maybe there's going to come a time where one test isn't going to be good enough. I don't know, Tom, you might want to say something because that's an area you've been doing a lot of work.
Yeah, it's controversial because it increases the cost. However, with HIV, syphilis, other types of infectious diseases, we often do screen with a highly sensitive test and then confirm with a highly specific test. If we get a test that's got both high, and I mean very high sensitivity and very high specificity, then we may be fine with that. And we certainly get along in many other infectious diseases with a single test. But I don't think we're fully there yet. What everyone forgets is that this epidemic's only been going on for 3 months, really. We're going to move into the finishing up a 4th month soon. And yet the rapidity in which diagnostics have been coming along are just truly phenomenal. So when you said stay tuned, I totally agree with stay tuned. Things will keep evolving. There's a question about self-testing, nasal swabs versus physician, healthcare worker administered nasopharyngeal swab. Is there a difference in sensitivity? Have you looked at that?
Well, I think there'll be a difference in sensitivity if it's an air swab, as we say, like if you just wave it in the air and then send it in, of course it's going to be negative. But if you try to get back there, I think there's increasing evidence to show that mid-nasal turbinate, nasopharyngeal, and oropharyngeal, depending on the time of infection. So if you're doing it early, it probably is going to be just as good. I think self-collected. There's some evidence, but the full validation of self-collected swabs, I think, is yet to be done well. That's an area where in sexually transmitted infections, a lot of work has been done by Charlotte Gatos here at Hopkins, and so she is very keen to think about how self-collected could fit in. I think that if we keep having people come to tents and stuff, I think this sort of self-collected and sending it in somewhere or dropping it off somewhere might be a better way to get better coverage. And the sensitive, you may not sacrifice much sensitivity if you're testing early.
Yeah, and that reminded me about testing in the frequency. So there's a rule of thumb for those still online that if you look at the percent positives over the number of tests administered in a community, if it's higher than 10% positive rate, then you're not doing enough testing. It should be below 10% positivity. That was a guideline that WHO had issued way back in the beginning. And for the US, many of our prevalence rates, and this is RT-PCR, was up as high as 20%. I think it's still high at Hopkins. You know, in China, they tested fecal material with RT-PCR for patients that had GI symptomatology. Should that be consideration for people who present with prominent GI symptoms?
Yeah, it could be. I think originally it was thought it might be particularly helpful in children who tend not to like cough out anything, and you wouldn't be able to get a good lower respiratory tract, but they tend to swallow, and so you might be able to find. So our stool positivity has been found. It's not as sensitive, I think, as nasopharyngeal swabbing early on, but you can get RT-PCR positivity. It's very difficult to culture out of the stool, so I think by the time it makes it through the tract, it's probably dead, but you can still detect RNA. So it's not an unreasonable sample type if you can't get anything else. But I think if it's early on in infection, I would stick to something that's getting at the respiratory epithelium where we think that the virus is or we know the virus is replicating. And then if it's later on in infection, you might want to try deeper in the respiratory tract. But for people where that's not an option, I think you could look at stool, but it tends not to be positive for as long in stool.
Yeah, I'm getting near the end of some of these. Do you want to say anything about reinfection? What's the evidence for it? Does serology help?
Well, I told you that serological responses can be nil in up to 5% of people, depending on the study that you look at. So I suppose in those people, it would be possible to get reinfected. I think we're all making an assumption that neutralizing titer will equal protective immunity. I guess we sort of don't know that. We also don't know how long people will keep immunity. So the longest, as CJ pointed out, the longest that anyone could have been infected right now with with COVID-19 is 6 months out, right? So we don't know if anybody holds immunity for longer than 6 months because nobody's had more than 6 months in which to know that.
Right.
There are patients who've gone from positive to negative to positive. Right now, based on the cycle threshold levels, I think many of those people are people who kind of dipped. They were sort of cycle threshold high and they kind of dipped down a little bit and then sort of came back up to a detectable range. Remember that all of the RT-PCRs are reported as positive, detectable, or not detected. But there are levels of the amount of RNA that we're seeing that you can look at that make me think that they're probably just hovering around detectability. But I think it's possible, I guess, to get reinfected if you didn't make a productive immune response the first time round. I haven't heard too many people who had severe illness, who got better, who got sick again. Most of them are sort of milder illness. It makes me think maybe that they didn't make a productive immunoglobulin response.
Mm-hmm. And they also asked about these certificates that if you're serologically positive with IgG, you get a certificate to go back to work. I just want to say WHO has come out and said that should not happen. We don't know the responses to that.
Yeah, I have nothing to add to that. I think that's right.
Let's see. There was another one that. Oh yeah. So, and then let me close with this one. Resource limited setting situation like this pandemic, considering the asymptomatic cases. There really a difference in using a qualitative versus a quantitative test. If there's no difference in test time, which one would be preferred once you're in a few weeks into the pandemic?
Well, that's an interesting question. I guess it brings up the question of why we don't actually have a quantitative result, but I think it's because we don't have anything to normalize the values to. So right now, if I do a Roche test, and then I do an Abbott test, and then I do a BD Max test or whatever, I do a different RT-PCR platform, I don't really know how to compare those across platforms. You can try to do comparative sensitivity, and some of those have been coming out and they seem relatively the same. But if I have a cycle threshold of 23 by one assay and 27 by another assay, can I follow that over time? And I think the answer is, unless you're on the same platform, I don't know how you compare that over time. And then there's all the sort of vagaries of the way you got the test. So when you say quantitative, I don't think actually there's a quantitative molecular test right now. That's why they say it's either detected or not detected, and they give you a binomial yes or no answer. So I think that's something we should strive for. It would be great, like with PCR, with HIV, we have these sort of ultra sensitive viral load to know if people are really suppressed. Might be really interesting. And I think we need to learn more about who's culture positive versus just RT-PCR positive. What's that threshold? Is there a threshold, or is that data from the skilled nursing facility at University of in Washington State a cautionary tale? I don't know.
Yeah, I said that was the last one, but now I see a couple other good ones here. What about herd immunity? And where does that factor in? Is it important to do serologic surveys to determine herd immunity?
I think there's a lot of controversy over the serosurveys that have been done thus far. I think the one that maybe has been circulated the most widely was the one done in Santa Clara, Santa Clara, right, in California. And I think there they found with quite large confidence intervals, somewhere around 2 to 5% positive, or 2 to 4% positivity, but the sample was small. So I think you're going to have to do really high quality, large scale serosurveys in order to be able to know. But at 5%, there's not a lot of herd immunity. There's a lot of people who are very susceptible. So the more successful you were at closing down your state or your country and having fewer people, all these countries that early on reported success against COVID-19 are now seeing cases popping up, and they're having to continue to be vigilant. I think that's been true in South Korea. That was true in Japan. That's also true in Singapore. I think they're all now struggling with new little mini waves. So the vigilance can't stop, even if you flatten the curve or manage to stomp out and done really good contact tracing initially.
That's great. I'm going to give the last word to Dave Thomas. I don't know if he's still on, but he wrote an important note. Probably goes without saying, but the performance of a test has to do with the job the test was designed to do. For diagnosis, antibodies are horrible early, which unfortunately is general when you're asking the question, what's the diagnosis of the patient? For tests of immunity, we also have no information. For infectivity, we're in a dark place, assuming culture is the gold standard, but we don't have hard data comparing it to culture. Any comments, Vatki? They've hit all the important notes on that one.
Do you mean
Yuka, sorry.
Yeah. So no, as usual, my boss says it well. I think there's a lot of places left for research, and I think we still have a lot to learn. I think serological tests will likely play a role in diagnosis of COVID-19, at least for population, to understand what percent of the population was exposed. But right now it's a very imperfect test with limited amounts of data, and I think we will have to wait and see what happens. So I think he's outlined the key areas where we still have a lot of questions. For those of you doing research, it seems like we might keep our jobs around COVID-19.
And I will close with this comment to you, Yuka and CJ. Thank you so much. This has been the best call I've joined on COVID to date. I do love diagnostics. Truly appreciate you presenting and going through all the questions as well. And I think that says it for all of us. You both of you have done a fantastic job. These are not easy questions to address. We'll probably revisit this many times in the future. And I want to thank everyone for tuning in. I will make an announcement that on Tuesday, May 5th, the next session will be building in implementing capacity and response. And we have David Peters presenting and Tolbert Nenswa from Liberia that will be doing a joint presentation for that. So institutional response and capacity strengthening to address the COVID pandemic. So thank you very much, everyone. Many thanks to Yuka and to CJ, and we really appreciate everyone tuning in. Thank you.